everyone. Welcome to NCVH Digital Education Series. This was to be our inaugural venous thrombosis VTE symposium, and hopefully next year we'll be able to all meet in New Orleans and discuss VTE in a meeting format that I think will be very valuable. But in the interim, I think VTE is a very important topic that we must all understand, and I want to initiate our discussion of VTE for this symposium for the Digital Education Series. I want to thank Dr. Walker and NCVH for hosting this, and today what I'm going to do is talk about why every clinician must understand VTE. Here are my disclosures. So the question, the topic of the day is, why does every clinician need to understand venous thromboembolism? So I'm going to present a few cases, and this will help highlight some of the importance of understanding VTE. And we'll go back to the cases at the end to show exactly where we went with these patients. So here's the first case, the cardio junkie. She was 41. She had no past medical history and had a few pregnancies, and her last one 2 years ago. She began an intensive exercise program and lost a lot of weight. She dropped her BMI substantially and was going to train for her first marathon. But after she lost her weight, she had excess fat in the abdomen and went for an abdominoplasty surgery. 3 days after this surgery, she developed sudden, severe shortness of breath and presented to the emergency room. And her blood pressure was at her baseline and heart rate was elevated. She was profoundly hypoxemic, requiring non-rebreather face mask. Her cardiac biomarkers were elevated. And if you see the echocardiogram, she had substantial right ventricular dilation with pressure overload, as you can see on the D-shaped septum, and there was McConnell's sign. Now, the CTA showed bilateral PE that was quite extensive. So what do? Do you admit this patient to the ICU and initiate anticoagulation? Do you place an IVC filter because she just had surgery and can't be anticoagulated? Do you set her for thrombolysis of some sort, or perhaps mechanical thrombectomy, or do you just give her systemic TPA? Well, in our case, in this patient, we'll be discussing all of the results of what we did with these patients at the end of this talk. But we're going to move on to the second case, which is the engineer with brain cancer. So this was a 36-year-old guy that was unfortunately diagnosed with a glioblastoma of the brain. And he received radiation treatment, chemotherapy, and ultimately had resection of the tumor. But this was complicated by right-sided motor deficits, and he had to go for intensive physical therapy. While he was at physical therapy, he twisted his right ankle and injured it. And while he was off from PT, he started to develop a very painful, swollen, and discolored right leg that just got worse. And he didn't have any shortness of breath. You can see his right leg was more swollen than the left. There was some redness there. His D-dimer was elevated, but the ultrasound did show an occlusive thrombus in the right deep femoral vein. So what do you do in this patient with a history of brain cancer? Do you initiate anticoagulation and tell him to follow up in a few weeks, place an IVC filter? Do you admit him to the hospital and initiate anticoagulation? Or do you send him for catheter-directed thrombolysis? Or do you just do something else? So we'll get back to that. The third case is what I call the forgotten police officer. He was a 38-year-old gentleman officer who didn't have any past medical history, but he developed some progressive shortness of breath over 1 week. He injured his leg a few weeks ago after he had an altercation with a suspect while on duty. But he hasn't been working since that time. Denied any leg swelling or ever having any pleuritic chest pain. Ultrasound of the leg didn't show any DVT. And he went to the emergency room just for evaluation because he was having some shortness of breath, didn't know what it was. And he had slight hypoxemia, requiring some oxygen, but everything else was normal. Cardiac biomarkers were normal, and the only thing that was abnormal was his D-dimer. So they got a CTA, given a shortness of breath, and lo and behold, he had a saddle PE. But what he did not have is any issues with his right ventricle. The RV and LV function were normal. His PA pressure was normal at that time. So the question here is, what do you do? Do you refer them for catheter-directed thrombolysis or mechanical thrombectomy? Do you administer systemic TPA, or just watch them in the hospital for a couple of days and then send them home on anticoagulation? Or do you just send them home immediately from the emergency room on anticoagulation? The last case is what I call the Katrina disaster. He was a 62-year-old former FEMA officer who presented for evaluation of non-healing ulcers, which he had for many years. He had chronic swelling of both legs after he injured them during rescue operations during Katrina. He was diagnosed with bilateral DVTs and had been treated with warfarin ever since. Over the course of several years, he had many infections requiring many hospitalizations for antibiotics, and on a few occasions they had recommended that he just have an amputation to the leg, and he obviously did not want that. So he came to us and showed us where he had one of his ulcers on his right leg and significant skin changes. He had a similar ulcer on the left leg. His ultrasound showed partially occlusive thrombus in both the deep and common femoral vein, but this definitely wasn't acute and not something that just happened overnight. And so the question is, what do you do here? Do you tell the wound care team to amputate, send him for amputation? Do you refer him for ablation of the superficial venous reflux that he may or may not have? You recommend aggressive compression therapy, or you send him for a venography and evaluation of central vein disease? Or do you just do both C and D? So let's look back in time to VTE, and in essence, it has been described way back in the Vedic era in ancient India by Ayurvedic physician Sushruta, who described a swollen and painful leg, but it wasn't known that it was a DVT at the time. And Morgagni in 1761 was the first to really identify clots in the pulmonary artery, but didn't have an idea of where it came from. Fast forward to the mid 19th century, and it was Rudolf Virchow who was the first to elucidate the mechanism of PE, in which he termed it embolia. So he was the first one to really identify where clots originate from and how they travel to lead to pulmonary embolus. And in his honor, he many years and decades and later, we understood that the triad or the tenets of developing VTE are endothelial injury, hypercoagulability, and abnormal blood flow. So VTE is a disease of very significant grave consequences. And according to the CDC, PE is the third leading cause of death after MI and stroke. In fact, it is the leading cause of maternal death in both the United States and the United Kingdom. There are more deaths from PE than breast cancer, prostate cancer, and motor vehicle accidents and HIV combined. 1 million are affected yearly, up to 100,000 die annually. A fourth with PE die of sudden death, and up to 30% die at 1 month. If you look at VT in general, 1/3 are going to have some form of recurrence within 10 years. And as we deal with pandemics in our world, I will say that VTE is a pandemic in its own right, with over 10 million cases per year of VTE diagnosed globally, greater than 700,000 cases per year in Europe, 540,000 VTE-related deaths in Europe annually, with significant increases seen in China. In the United States, 1 person dies every 6 minutes from a pulmonary embolus. In the world, this equates to 1 person dying every 15 seconds. So diagnosing PE can be a challenge, but when you look at autopsy findings of patients who were diagnosed with PE, only 18% of these patients had a pre-mortem clinical suspicion of PE, so we miss pulmonary embolus, or they never get to the hospital. The signs and symptoms can be nonspecific with a large differential diagnosis attached to it. While one of the concerns is missing the diagnosis and getting sued, I think the issue, more importantly, is the benefit of the patient in avoiding the long-term sequelae of the disease. For example, in pulmonary embolus, chronic thromboembolic pulmonary hypertension is a very morbid condition. as well as post-thrombotic syndrome in the case of deep vein thrombosis. For CTEPH, when we look at is that over 60% of, up to 60% of unresolved clot can persist at 1 year. And 4% of patients can develop CTEPH. But almost half of these patients with PE will have some form of persistent exercise limitation. And for post-thrombotic syndrome and DVT, almost a third of patients will develop some form of post-thrombotic syndrome, which can cause significant conditions, morbid conditions that can affect their quality of life. And a lot of these patients are unable to work after about 10 years from their diagnosis. And we all know that anticoagulation is our option. Of all patients are going to be anticoagulated unless there's a major contraindication. But the misnomer amongst some of our patients, and even maybe amongst some clinicians, is that the anticoagulation is dissolving the clot, when in fact, it is just making or preventing the clot from getting worse. It allows the body's natural clot busting mechanism to become activated and allows plasmin to aid in clot dissolution. But unfortunately, our body does a very poor job of breaking down large clots and oftentimes leaves behind scar. So the algorithms for treatment of PE are so forth. We have various categories based upon some guideline data from the European Society of low risk, moderate risk, and high risk PE. When you have a high risk PE, the decision point is simple. You want to evaluate for early intervention if they're a candidate, such as systemic lysis or surgical embolectomy, or send them straight to the cath lab. If they're low risk, meaning they don't have any RV strain or elevated biomarkers but are diagnosed with PE, these are patients we treat with anticoagulation. Now, if they're moderate risk, they typically have some form of RV strain and a potential elevation in cardiac biomarkers. This can be further risk stratified into low risk moderate or high risk moderate submassive PE. In the low risk category, you typically have RV strain without any other findings, and in the low risk, you may have all of the above. The traditional dogma is that when you have high risk moderate submassive PE, to send them to for an early intervention to the cath lab for surgical embolectomy or systemic lysis, and if it's in the low risk categories, anticoagulation. But there may be some gray zone in between, and ongoing research is going to help us identify if we can take patients sooner, and even based upon the burden of clot that they may present with. What we know is that RV dilation is an independent predictor of death and hemodynamic collapse when the ratio of the RV to LV is greater than 0.9. And I mentioned clot burden for an important point in that in prior studies, we have seen that the thrombus load does relate to, is a predictive predictor of mortality and adverse clinical outcomes. And I think we're going to have to understand more about clot burden to determine how we can better risk stratify our patients going for interventions in the cath lab suite. For DVT, we define an acute DVT as being present for less than 14 days, and we can split it down into three separate entities: distal, femoropopliteal, or iliofemoral. The distal DVT, the question is, are they symptomatic or not? And if they are, we can anticoagulate them, and if they're not, we observe them. If you have an iliofemoral DVT, the next question to ask is, do they have phlegmasia, which you can see indurated, swollen legs that causes substantial pain? If the answer to that is yes, consider intervention. If the answer to that is no, the question is, should you intervene or just treat with anticoagulation? The decision is really based upon patient preference and also whether or not they have evidence of impending phlegmasia. Where it's really complex and difficult to ascertain as far as the optimal treatment is femoropopliteal disease. Most will receive anticoagulation alone, but in some cases, consideration for intervention in the cath lab suite if they have impending phlegmasia can be considered. And of course, if you're a contraindication to anticoagulation, we proceed with IVC filters. So the ATTRACT trial looked at pharmacomechanical catheter-directed thrombolysis, and on the surface was a negative study, but when you look closer and closer inspection, patients with moderate to severe PTS was reduced when you use pharmacomechanical catheter-directed thrombolysis. And in this study, the utilization of devices were infusion catheters, the angiojet device, and trellis, which is no longer available. So identifying patients at risk for post-thrombotic syndrome is an important, it will be important for all clinicians. Understanding a Volta score. What is your risk of having a post-thrombotic syndrome? So it's a scoring system based on various parameters from 0 to 3, 3 being the worst symptom. And if you're above 10 to 14, you have moderate PTS. If you have greater than 15 scoring, you will have severe PTS. And these are patients you want to consider for early intervention. There are various devices, interventional options beyond anticoagulation that we can utilize, including catheter-directed thrombolysis with the Ecosonic catheter or McNamara catheter. We have pharmacomechanical thrombectomy utilizing the angiojet device, which is a rheolytic form of therapy that also has an ability to aspirate thrombus, as well as infused therapeutic drugs such as thrombolytics. We have mechanical thrombectomy devices such as the FlowTriever and ClotTriever devices that do not require thrombolytics, but can extract a substantial clot for both DVT and PE. And we have the Penumbra, Penumbra device, the Cat8 device that is utilizing continuous aspiration for extraction of clot in DVTs, as well as other locations. So let's go back to the cases and discuss these in detail. So let's look at case one of the cardio junkie, the one that had the surgery very recently and had weight loss. What do you do? In this case, we decided and opted for mechanical thrombectomy. She is not a candidate for any catheter-directed thrombolysis or lysis in general. She just recently had surgery, and that would make her a contraindication. She is not a contraindication for any anticoagulation for her surgical physician. So we opted for mechanical thrombectomy because she had a submassive PE with RV strain and elevated cardiac biomarkers. And you can see her PA gram showing significant thrombus in the right pulmonary artery branches, as well as the left lower pulmonary artery branch. And after using the Triever 20 aspiration device, we were able to extract substantial thrombus. We utilized the FlowTriever device to extract some more adherent thrombus. But the most important slide to me is this one, which shows the substantial drop in her PA pressures. Her mean pressure went from 40 to almost 18 instantaneously, with almost instantaneous improvement in her breathing. And I think that is the most satisfying part of these cases. And now we'll move on to case two, which was the patient with the glioblastoma who developed a DVT in the right ankle swelling. This patient, when we considered, had significant impending phlegmasia. We talked to his neurosurgeon, who felt that he was a candidate for anticoagulation, but obviously he would not be a candidate given his prior brain cancer and surgery for any form of thrombolysis. So we opted for something else in this patient because his quality of life would have been significantly affected if we did nothing. And what we did was we extracted clot from his thrombotic femoral vein using the ClotTriever device, achieved a very good result. And you can see that his right leg immediately after the procedure was not red and not swollen. And this is the type of clot we were able to extract. Now, the third case was the forgotten police officer, the gentleman who developed some swelling in the leg, injured the leg, but I'm sorry, he did not have swelling. He had injured his leg and had some no pain, didn't have any elevation cardiac biomarkers, looked fairly well except for some shortness of breath. He had the saddle PE with the normal RV size and function, no pulmonary hypertension, but a very scary looking embolus in his pulmonary artery when he first presented years ago. What do? Do you refer him for urgent catheter-directed thrombolysis or mechanical thrombectomy? Do you administer systemic TPA? Put him in the hospital for a few days, see how he does on anticoagulation, or just send him home from the ER with oral anticoagulation? So when he was first seen at the emergency room, they decided to admit him to the hospital, just watch him for a few days. His family doctor admitted him and is watching. He's totally stable throughout, didn't have many complaints. His breathing actually felt like it was getting a little bit better, so he went home on a DOAC. But in retrospect, we had wished that this gentleman had gone for catheter-directed thrombolysis or mechanical thrombectomy. What happened to him was he had progressive exercise intolerance since the time of his PE, had to quit his job and get on disability. He had significant pulmonary hypertension with a PVR of 5.6 Woods units, and he was ultimately referred to Pulmonary Hypertension Center for therapy. This is not his lung imaging, but this is what you can get, where you get scarring and thrombotic material that's essentially like collagen within the pulmonary artery, and can treat with embolectomy. There's novel vasodilator medications, and you can see a PA-gram without any filling in some of these branches. But this leads to the question of thrombus load and how we treat these patients. If you see a large thrombus, yet you can see it, you don't see, things like this can happen where they don't have a clear classification into the submassive category, but you had that large clot. Should these be patients that we take to the lab? And I think future research should help us identify that. And finally, the Katrina disaster. There's a gentleman who was a FEMA operator who helped people during Katrina and developed DVTs in his legs and recurrent cellulitis. What do you do for him? For him specifically, what we did was we wanted him to have aggressive compression therapy, as well as evaluate him for his central veins to see if he had any occlusive disease, which we strongly suspected. Superficial venous reflux is something that you could consider, but given his non-occlusive thrombus in his deep femoral vein, we opted to leave his superficial venous disease alone. And obviously, we don't advocate amputation unless it's there's no other options. So we looked at his angiogram, his venogram, and he had complete occlusive disease with collateralization in the bilateral iliacs. And we were surprised, actually, we didn't know about an IVC filter that was in place, but luckily not thrombosed. We were able to pull that out with some compression, some pressure. And from there, we were able to stent his iliac veins, get a good result. You can see there's no collateral flow filling, which indicates that the flow is good. And after a month or two, he was able to start healing his wound, and both of his legs have been healed. And so with that, I'll conclude by saying that every clinician should understand VTE, because quite honestly, we're all going to see it. We all see it many times over, and patients suffer greatly from it. And nowadays, we do have many options for treating these patients. When in doubt, regarding the options, if you're in a community hospital and you may not have these options of therapies in the cath lab, it's always, I advocate just picking up the phone and calling and asking somebody who treats this routinely, because if we could treat it earlier rather than later, we can really have a tremendous positive impact on patients' life. And so with that, I thank you all for your attention, and I look forward to seeing you next year at NCDH.